For millions of people, a simple wound just isn't that simple. When the healing process stalls, a really complex set of rules kicks in to decide what kind of care gets covered. So today, we're going to break down Medicare's official playbook for wound care.
Think about it. For a huge part of our population, healing isn't a guarantee. When a wound just refuses to close, getting the right treatment is absolutely everything. But who's the gatekeeper here? Who decides which cutting-edge treatments get the green light and, more importantly, get paid for? And what are their rules?
Well, the answer is kind of hiding in plain sight. It's inside a, let's be honest, pretty dense government document that's basically the official game plan. It's a detailed rule book, and it's designed to separate the proven, effective treatments from the ones that are still considered a bit experimental. And it all comes down to a simple phrase.
So this document, it's called a Local Coverage Determination, or an LCD for short. And that phrase I mentioned, reasonable and necessary, that is the entire foundation of this whole thing. It is the high bar that every single treatment we're about to talk about has to clear.
All right, so where do we even begin? Well, we've got to start with the absolute bedrock of wound care, a procedure that's almost always the very first step, debridement. The official definition is really all about cleaning the slate. You can't build a new house on a rotten foundation, right? Debridement is basically the demolition crew for a wound. Its job is to clear out any of that dead, contaminated, or damaged tissue, what doctors call devitalized, to give the healthy tissue underneath a clean, fresh base to grow from.
And let's be clear, we're not talking about a skinned knee here. Medicare only covers this for really serious, complex wounds. We're talking about things like advanced pressure sores, nasty diabetic foot ulcers, or even injuries so deep that bone or hardware is exposed.
So what's the point of it all? Well, the goals are pretty straightforward, and they are absolutely essential. When you remove all that unhealthy tissue, you're not just making room for new growth, you're actively slashing the risk of infection, and hopefully preventing the wound from getting a whole lot worse.
Now, not all debridement is the same. The approach can be totally different depending on the wound. On one hand, you have what's called selective debridement. This is precise, delicate work, almost like a sculptor carefully removing only what's necessary. And on the other hand, you have non-selective debridement, which is a much broader, more aggressive approach that can be a full-blown surgical procedure in an operating room.
Okay, and this part is crucial. Medicare isn't just paying for effort, it's paying for results. There's a clock ticking. If that wound isn't showing clear, measurable improvement within 2 to 4 weeks, the rules say the treatment plan has to be modified. No excuses. Okay, so that's the basics. But what happens when debridement alone just isn't cutting it? Well, that's when the advanced therapies come into play. But to get covered, every single one of them has to pass what we're going to call the evidence test.
First up, we have something called negative pressure wound therapy, or NPWT. It's a pretty cool piece of tech, actually. It uses a special dressing and a pump to create a gentle, controlled vacuum over the wound, which helps pull it closed, manage fluid, and encourage new tissue growth.
But here's where that evidence test gets really tough. Even though it's a common treatment, the official Medicare analysis says there's simply not enough evidence to support its routine use. That's a big deal. It means Medicare sees it as more of a last resort, something you try only after the more established treatments have failed. Now let's compare that to another technology called mist therapy. This one is different. It uses a low-frequency ultrasound, kind of like a focused beam of energy, to gently stimulate the wound bed and kickstart the healing process, all without ever actually touching the skin.
And this is a perfect example of how powerful evidence can be. The analysis for mist therapy points directly to a big meta-analysis. That's a study of other studies, so it's a really strong form of evidence, which found it healed wounds almost twice as effectively as standard care. Now, that is the kind of powerful proof that makes getting coverage a whole lot easier.
But of course, that coverage comes with a catch, and it's a strict one. Just like with everything else, progress is the name of the game. For mist therapy, the rules say there must be documented improvement after just 6 treatments. If not, Medicare considers it no longer reasonable or necessary, and the coverage stops.
All these rules and evidence tests, they all point to what might be the single most important piece of this entire puzzle. It's not just about what treatment you give a patient, it's about what you can prove you did on paper. This is where the documentation, the rules of proof, becomes absolutely critical. At every single visit, that medical record has to be completely airtight. Think about it from an auditor's perspective. They have to be able to look at that chart and see everything, no questions asked. We're talking precise measurements, notes on infection, a detailed description of any tissue that was removed, and a clear update on how things are progressing. Every detail has to be there.
And this quote, which comes directly from the LCD document itself, just says it all, doesn't it? It's not good enough to just write down, the goal is for the wound to heal. Nope. Providers have to set what are basically SMART goals, specific, measurable benchmarks that create a clear, undeniable roadmap for the patient's treatment.
And this isn't just random notes in a file either. Every treatment has to be part of a formal, certified plan of care. And get this, for ongoing procedures like debridement, the document actually recommends taking photographs. I mean, what better proof of progress, or lack thereof, is there than a picture?
Okay, so to wrap all this up, there's one last, really important thing to get. This rulebook, it isn't some ancient text carved in stone. It's a living, breathing document that is constantly changing.
Just look at the history. This policy is not static. Back in 2020, for instance, a major revision expanded coverage for certain types of ulcers. And why did that happen? Because providers in the medical community formally requested it. They brought new evidence to the table, and it shows that this system is actually designed to listen and adapt.
Yeah, there's a whole formal process for this called reconsideration. So if some groundbreaking new research comes out for a therapy, doctors and providers can literally package it up, submit that evidence, and formally petition to get the rules changed.
This chart gives you a little peek behind the curtain at how Medicare actually grades the science. And you can see that, while the quality of some studies might be rated as moderate, the overall strength and weight of that evidence is often seen as limited. And that gap right there? That's exactly why a constant flow of new, high-quality research is so vital. It's what closes the gap and changes the rules.
So in the end, this rulebook we've been taking apart is really just a snapshot in time, based on the best evidence we have today. The real question, the one we're left with, is this. As wound care technology gets smarter, faster, and more effective, how will the rulebook keep up? Will the definition of reasonable and necessary lead the way, or will it always be playing catch-up with the science?